Rohit's story, like that of countless others, began not with a whisper, but with a sudden, excruciating jolt of pain. We open on him in the emergency room, his face a mask of agony clutching his side. The fluorescent lights of the hospital seem to mock his discomfort. A doctor, her expression a mix of concern and professional focus, leans in to speak. This is the moment where the journey to a diagnosis begins. A path paved with questions, examinations, and technology, all aimed at uncovering the source of his suffering. It's a journey that starts with one of the most severe pains a person can experience, often described as worse than childbirth or a broken bone. The doctor's immediate task is to rule out other serious conditions and zero in on the likely culprit, a kidney stone. The first step in this diagnostic puzzle is gathering a detailed clinical history. We see a doctor meticulously taking notes as a patient recounts their experience. On-screen key questions flash, illuminating the classic signs of renal colic. Was the pain sudden? This is a hallmark of a kidney stone, appearing without warning and escalating rapidly. Does it radiate to the groin? This specific pattern of pain occurs as the stone travels down the ureter, the narrow tube connecting the kidney to the bladder. Are you experiencing nausea or vomiting? The intense pain often triggers these systemic responses, adding to the patient's misery. A history of prior stones, family history, or dietary habits can also provide crucial clues, helping the physician build a preliminary case for a kidney stone diagnosis. Next comes the physical examination, a hands-on approach to confirm suspicions. A doctor is shown performing a gentle but firm tap on a patient's lower back, specifically over the costovertebral angle, which is the area where the kidneys are located. The patient visibly flinches and shifts uncomfortably, a positive sign known as CVA tenderness. This reaction is a strong indicator of inflammation or obstruction in the kidney on that side. While the patient's abdomen might also be tender, the most significant finding during the physical exam for an acute kidney stone episode is often this specific back pain, pointing the diagnostic arrow directly toward the urinary system. With the history and physical exam pointing towards a stone, laboratory tests are ordered to provide concrete evidence. We see a close-up of a urine sample which may appear cloudy or tinged with pink. A subsequent microscopic view reveals the truth: an abundance of red blood cells, a condition called hematuria. Even if the urine looks clear to the naked eye, microscopic hematuria is present in about 90% of cases. Simultaneously, a blood sample is drawn. The results flash on a screen, showing the patient's creatinine levels. Elevated creatinine can indicate that the stone is obstructing the flow of urine and affecting kidney function, adding a layer of urgency to the situation. To pinpoint the problem, imaging is essential. The scene shifts to an ultrasound probe gliding across a patient's abdomen. On the monitor, the sound waves paint a picture of the kidney, and the trained eye can often spot the stone or signs of blockage, like a dilated kidney, hydronephrosis. While ultrasound is a valuable first step, especially for pregnant women and children, the definitive gold standard for diagnosis is a non-contrast computed tomography, or CT scan. We see a patient being moved into the sleek modern ring of a CT scanner. Seconds later, a crystal-clear cross-sectional image of the abdomen appears. Digital arrows precisely point to a small, bright white object lodged in the ureter, revealing its exact size and location. This level of detail is critical for planning the right treatment. Ultimately, the size and location of the stone dictate the next steps. An animation vividly illustrates this concept. A small stone, perhaps less than 4 millimeters, is shown being flushed out naturally with the help of fluids and medication. In contrast, a larger stone, greater than 10 millimeters, is depicted as being too big to pass, requiring intervention. This is where Rohit's journey leads him next, from diagnosis to a discussion about treatment options like shockwave lithotripsy or ureteroscopy. The initial agony in the ER has been replaced by a clear understanding of his condition, all thanks to a methodical and thorough diagnostic process that turned a painful mystery into a solvable problem.